Good morning. Thank Vanita for this course, which she does time and again, and it's a huge success in almost all meetings here. And our talks have also evolved with the course along with time, I should say here. So welcome on this post-banquet day at 8 a.m. And I think there's a slight change in the sequence because the earlier speakers are just on their way to the hall. Have no financial interest in the mention of any of the devices, procedures during the course of this talk here. Toric tantrums. Preoperative astigmatisms in patient undergoing cataract surgery, you would find more than 33% of the eyes undergoing cataract surgery will manifest with over one diopter of astigmatism. Hence, the need to look at the various options of how you would handle astigmatism during cataract surgeries here. So we're not delving into the basics, but we're going to delve on the pearls which are required when one is considering incorporating toric IOLs into his or her practice here. So the first is to know where you would not want to use toric IOLs here. So corneas which have been altered by scars, corneas which have ectasias, post-LASIK corneas where the irregular astigmatism quotient is higher, then these corneas are not corneas which would be befitting a toric IOL implantations. Eyes with zonular instability, for the simple reason that rotating the IOLs in the bag, which probably compromise the bag status, is again a no-no for implanting toric IOLs here. With a posterior capsular dehiscence, again for the same reason that rotation and placement on the right axis is going to be unpredictable. So posterior capsular dehiscence is also one of the contraindications here, where there's poor pupillary dilatation. Then you would probably need to augment with intraoperative pupil management devices for better visibility if you're doing such cataracts here. And eyes with prior VR surgeries, glaucoma surgeries, these are eyes where the ocular surface is compromised and the component of astigmatism is something which is going to be difficult to control in these eyes. So this is something you need to be considering, but by and large, with the way IOL implantation and IOL practice has changed, most of these indications have now moved on from being absolute contraindications to relative contraindications. So that's how the scenario of toric IOL implantation has changed with time. So what do you need to know next? You need to know the evaluating devices which will help you to estimate the amount of pre-existing corneal astigmatism here. So what are the devices which you have in hand is that your simple manual keratometry. You have automated keratometry, whichever device you choose to have, either IOL Master 700, Lens Star 90 or various other entrants which are there. You have the OpScan 2, the Pentacam, the Galilei, the Cassini analyzer, iTrace, and the intraoperative aberrometry by form of the Aura. So these are the various devices which I have used and have experience, and these are ones which will help you to estimate the quantum of preoperative astigmatism here. So when you use evaluating devices, I think keratometry has a very imperative role in the amount of astigmatism which you are estimating, and also in the calculation of your spherical power of the intraocular lens which needs to be implanted here. So evaluating ocular surface is a very imperative process, and most of these patients, being elderly, postmenopausal women, having other associated diseases like rheumatoid arthritis, Sjogren's, and if their ocular surfaces are compromised, that's something you need to optimize and evaluate these with the ocular surfaces by simple in-office ocular surface evaluation tests, or if you have a dry eye suite to your axis, then ocular surface analysis looking at the tear film breakup time, and various other parameters will help you to understand whether you need to optimize the surface further before you move on to finalizing the IOL power estimations here. So this is one scenario where you will really need to look at the surface more carefully here. Looking at the ocular aberrations is one which is important to look at the multifocality of the cornea, which you are going to be treating with a toric IOL implantation here. So those corneas whose multifocality, whose Q values have been altered by either they have higher quotients of irregular astigmatism by something like ectasias, keratoconus, or there is a post refractive surgery component here. corneal scars, and these eyes are eyes which have higher order aberrations here. And in the event of presence of corneal higher order aberrations, then you would not want to an toric implantation, because that's going to make the patient more unhappy here. So that's something, please remember, those aberrations which are arising because of the lens, the lenticular aberrations, are what we can correct, because you're removing the lens and you're replacing it by an intraocular clamp. But those corneal aberrations, if they are very high, then these are going to be unhappy patients, because those aberrations are going to persist after your surgery, and your toric implantation is not going to correct them. So that's how you learn to evaluate in which scenario, in the presence of irregular astigmatism, you can implant a toric or not a toric here. So pretty much we do see patients like this most of the time when they come and they are elderly. You have thickened lids here, they do have meibomian gland dysfunctions, and these are eyes again which need to be carefully evaluated for their keratometry and for their astigmatism estimation. And again, intraoperative copious use of viscoelastics on the surface so that the epithelium is not compromised is something which you need to look at in these patients here. Okay. Optimizing the ocular surface in the perioperative period is imperative for the reasons which I've already emphasized to you, and that's going to be sometimes the most important aspect when you're managing these eyes. So what are the steps you need to know of? So I've already told you it's preoperative planning. So spend some time. It's not just looking at the cataract and looking at the intraocular pathologies which are associated or comorbidities or posterior segment evaluation. You will also need to spend your extra few minutes to look at and please finalize your IOL power and the lens and your other parameters before you take the patient onto the OTO and before you send the patient on for your counseling here. On the day of surgery, what's important is the marking of the axis. So a proper and improper marking several times would be probably the reason why the patients are unhappy or is a wrong implantations. Again, remember, marking most of the time our patients are in the supine posture, in the sitting posture, and when you're doing surgery they are supine, so you will have to consider some amount of cyclotorsion in these patients when you are implanting toric IOLs, more so if the quantum of astigmatic correction is going to be higher. Cyclotorsion component is something which needs to be considered in these patients here. Proper intraoperative alignment. The error which I do see my residents making commonly is erroneous placement of the Mendel's gauge when they are placing to mark. So if they do not know how they will have to orient the axis marker on the ocular surface, that can also lead to errors when they are implanting the IOLs. And of course the postoperative management is probably not going to be possible given the limitation of time that would usually largely cover if your lens is implanted in the long axis. Then how would you probably manage that scenario? And I think I would ask Vinita to incorporate this as a separate talk next time, because that will help people to understand. So it's not only the pre-surgery and surgical component, but I think part of it does get covered by refractive surprises by I think Rishi covers this aspect when he's taking. So you also need to know the magnitude of astigmatism, the axis of astigmatism, the realistic expectations of the patient, what is the type of IOL you're implanting, because we now have toricity, which is not only in monofocals, you have multifocals and you have trifocals, which are also coming with the toric components. So this is something you need to be aware of here, and also look at the ocular comorbidities of the patients, not just surface comorbidities, but also the other limitations which would limit the vision capabilities and potentials of the patient, and particular attention to the IOL power calculation here. Cyclotorsion, as I already told you, the range of cyclotorsion could be as high as close to 30 degrees here, and it can be over about 60 cases or above can have a higher quantum of cyclotorsion here. So that's an aspect which you need to look at, and this is going to then alter the preciseness of your toric implantation here. So hence you have devices which help you to gauge the astigmatism intraoperatively as well, or image guided devices devices which have come in preoperatively as well to enhance your results in quantum of astigmatism estimation here, and translating it onto the patient irrespective of the position the patient is in. So manual preoperative marking could be conventional 3 steps or 2 step ones, which are manual methods here in forms of a bubble marker or the pendulum marker here. I think most of us do still use this in our practice, and it works perfectly well once you have perfected the technique of using it. Image guided ones, you have preoperative and intraoperative. The preoperative one includes the Varion, which is the cataract refractive suit, which helps to gauge your intraoperative astigmatism, and you can it's transferred onto the console, and then this will help you to modify or to implant your lenses. The intraoperative one, which is more sophisticated and more expensive, is the ocular response analyzer, which you would need to do the intraoperative aberrometry. I think because of lack of time, I'll just run through. Please remember, one improper method of aligning your for axis marking is here when it's not passing through the center of the pupil. So correct estimation of the slit lamp guide is important, so that you mark accurately in these patients. These are the common errors. Some pictures of the bubbles. You do have apps which can help you and guide you for toric implantations and for marking as well. These are some of the apps, but I don't personally use them here. I think we'll skip the surgery. It's pretty much similar, but just remember, when you're implanting the IOLs, you'll probably implant them 10 degrees short of the intended axis, so that you always rotate your lenses clockwise, so you have that amount of leverage for the IOL rotation when you're removing the viscoelastics. So that's something you need to be wary of when you are implanting intraocular IOLs. These are pictures representative of the use of Varion during surgery and how the Varion marking helps you. So these are markerless solutions, and these Varion images will appear in your eyepiece. So they're also there on the console monitor, and the console monitor helps you to guide, and you do not need to mark these solutions, and this takes care of the cyclotorsions of the patients as well here. So those are simple alignments. We won't run through the videos. You also have systems which are there in the microscopes, which will help you to gauge your astigmatism, and that is again another markerless solution, and really helps you to look at. These are those markerless of Varion, and now we also have these incorporated in flax, the way you do your capsulorhexis, which marks the capsulorhexis margins, and then you can look at and use it for placing your IOLs here. I think this is just a representative image of the aura, which images intraoperatively here, and it then moves on, and the console chooses the right power of the IOL and the toricity of the IOL which you need to implant, and once you've implanted, it images and gives you which way you need to rotate, and if you're on the right axis, it says no further rotation required here. So these are all sophisticated ways of which you can, these are post-operative estimations using the eye trace, which will help you to show how much of rotation is there, and if you need to manipulate these rotations, or if you need to go back to rotate the IOLs in the event if the placements are erroneous. Yeah, I think I will stop here in the interest of time, and perhaps we can take more during the discussions. Thank you, Vanita.
Pterygium along with cataract.
Yes.
So in those cases, how do you proceed? You do
by and
radiation
large,
surgery and then do intraoperative aberrometry.
They are younger patients, fleshy pterygiums, and the quantum of astigmatism is higher, then it is always better to handle your pterygium first, and then take the patient on for the cataract estimations once the surface is optimized. Yeah, so that could vary anywhere between 4 to 6 weeks or 3 months. But again, atrophic pterygiums, we tend to think their astigmatism is lesser. You might have astigmatisms more, and if there's a scarring associated on the surface, then that's something which you will have to be incorporating into your planning as well. Yeah. There are now incidences, if you have lesser astigmatisms, then people do tend to handle them simultaneously, especially in uneyed patients. Yeah. Varion? Sorry, I didn't get you. Yeah, I think you can go to the, it's with the Alcon, no financial interest here. So it's a refractive suite, and it does come with a particular cost, but if you have a high volume of practice, then I think it's a very easy device that in the sense that you don't need to market everything, the machine. It also helps, it has other features of helping you to plan as well. You also have to learn how you need to use your cataract refractive suite. I would not be aware of that. I think you need to talk to that. Thank you.
Thank you, Anati. That's what she told. She said that.
I always do 3 months, yes. But I do see that's because probably we are all cornea people as well. But I see the cataract people are impatient even to wait for 3 weeks.
I know. Yeah. But if you're planning to put a toric IOL, I think it's always
definitely
a good idea
3 months. And more the better always.
Yeah, so I'll go ahead with the next talk. Actually, it should have been followed by the basics principles of how to do a good measurements of keratometry and excellence, but the first speaker has not reached probably in time. So I'll go ahead with my talk. Project kar dijiye, please. Nahi aaya hai us. Okay. So I'll be talking about optimization for your own results for every patient of your cataract whom you're going to operate upon. That's the way to go. That's what my take is, and that's what I'll propagate. We have an armamentarian of IOL formulas with us. Still, we land up with refractive surprises. So why is it? So is there a problem with the formulas? Yes. Each formula has its own limitations. So no statements. There are statements, SRKT is good for long eyes, Hofer Q is good for short eyes, but are these the correct statements? Because still with these formulas in those appropriate eyes also we'll end up with refractive surprise. And this is one example which show you with same readings of your basic keratometry and excellence and using 4 different formulas which I have shown, you'll have so much of variation of the IOL part calculation. So this is the reason we are landing up with refractive surprise despite our best efforts of doing the best measurements and the best IOL power formula which we have incorporated and used. So what is happening? Because of these problems which are inherently there, I may be choosing incorrectly, and I may be landing up with a patient where I have done an excellent surgery, my cornea is pristinely clear next day, eye is quiet, but the patient is still unhappy. This is because he has landed up with a high refractive error. So what do I do? The need is the optimization. Because as Vanity said, not even the toric IOLs, every cataract surgery is now a refractive surgery. So what are the other sources of error? Besides the measurement errors like the corneal compression, the calibration errors, there are certain inherent errors which we are presuming, like the speed of light, the refractive indices, and certain erratic errors which I'll be listing. This is, remember, every patient's anterior and the posterior segment of the eye are not exactly proportional for every patient. So then we have the sources of error which are arising because of the IOL designs. The angulation, their overall size, the shape, the rigidity of the optic haptic junctions, their biological interaction with the capsular bag which may vary from eye to eye, and the effective lens position which obviously another speaker will be talking about. So we all know short eyes produce a shallower ELP and longer eyes will result in deeper ELPs. And then we have the surgical technique which varies from surgeon to surgeon. So your axis size, how your lens gets centered, where is it being placed, whether you have done a very thorough viscoelastic removal or not, what is your suturing in case you are applying a suture, and the use of postoperative steroids which modulate your wound healing. So the IOL formula, if we just take by the simplest of the form, we all know is lens constant and axial length and keratometry are the 3 factors which are the important factors. And these lens constants which are given by the manufacturers have multiple variables included in them. So the A constant which we all know which is mentioned on the IOL box, it is an empirical value which is being provided by the manufacturers of the lens. And this has been based on certain theoretical considerations with limited clinical data and experience with similar lens designs in the past. This is how they have derived, the manufacturers have derived at it. And these constants, however, remember for every formula they are different. We have for holidays surgeon factor, for Hoffers we have the PACDs, for Hagies we have A0, A1, A2, all these which are used as a starting point. But remember, for optimization of your own results, you need to have these basic ingredients which we all do when we are doing a cataract surgery, your preoperative keratometry, axial length, IOL power in the model which you are choosing, and your post-operative refractive errors of your previous cases. So for your optimizing your own results or finding your own optimized A constant, you need to have previous experience of your previous cataract surgeries and their post-operative refractive errors. Remember, this can be done, optimization should be done for your own cells, so you should be not using cases for taken or operated by different people. One surgeon, one lens model, one biometry setup, one style of surgery, in the back placement of IOL, and a standardized refraction done by one person. So all these things should be there when you are doing optimization of your own results also. So an example is like we take this SRK formula. As I said, this is the basic formula. If we rearrange, this is how we derive at the A constant. Now, let's calculate the A constant for a case of series, average these values, and use this new A constant for your future IOL power calculations. For effective and a meaningful result, you can just take 25 of your cases with all those prerequisites I said: one surgeon, one biometry machine, one type of surgery, one type of IOL design in the back placement. So all these things, take your 25 cases with their post-operative refractive error, do the back calculations, and you'll be able to derive at your own optimized A constant. So back calculate for every case, as I said. But if you start doing these back calculations for these surgeon's factor or these A constants, it is very, very complex mathematics involved. There is also another method which is described, which is the Aristotle methods, where the predicted error is given as measured value minus the predicted post-operative refractive error. And for this, you need to have at least a sample of 100 eyes. So all these require a lot of paper and pen optimization, and this can lead to a lot of time-consuming aspect, and besides this, lots of errors, human errors which can arise. So more sensible would be to use a biometry machine to do this optimization for you, or use a separate software. So using the biometry machine, you can use that, enter the post-operative refraction in your biometry machines, and the machine will calculate and update the relevant A constants for you. Or a simpler method than this is using a software on your computer, which can be done at any point, sitting anywhere, on your desktop, on your laptops, or even on your mobiles now, with the updated software in it. So easier to transport data in this, faster, and no memory-related overload issues which may be there with the biometry machines. So this is one lens constant optimizer which was designed by one of our person with whom we started this course, Saurabh Sani. And also we have Dr. Hill's spreadsheet, which is available online. So this is a format of the lens constant optimizer. How does it work to give this? So it gives you a suggested A constant, like this is conventional optimization of the optical and the ultrasonic biometries. Same way it gives you after the conventional optimization. And we have something called as, beyond this conventional optimization, we have something called as DIO, which is another software developed by the same person I'm talking about, Dr. Saurabh. And again, we have the Holiday IOL Consultant also, which are both available softwares, which are both paid. They are not available for free as compared to the lens constant optimizer, which is available for free. And what does this DIO, since it is developed by one of my colleagues, so I'm just talking about it. It maintains your database. It performs extensive data analysis, produce optimized IOL power, and a single IOL power is provided. You need not worry which formula is better or which formula is bad. So everything is automated. Just need to bring in the basic parameters. You need to feed the basic parameters and it will work for it. And so in the end, I'll just say, is optimization worth the effort? Yes, it is. Because with optimization, you're able to receive the same result in almost 90% of surgeries as opposed to without optimization in 70% of cases. And with DIO and using ultrasonic biometries, it is almost 96% of surgeries. And using optical biometries, it's almost 99% of cases that you will have within plus minus 1 diopters. Thank you. So I would say, yes, optimization is worth it. Thank you. So I'll now invite about Dr. Shalini. She'll be talking about unusual circumstances. Yeah. You're taking average keratometry? I didn't get your question, sorry.
Keratometer is reading.
Yes.
I take 3 reading. This excessive different and this cylinder reading. So which one we have to select?
So that's why, so whenever you have, she'll be talking about it. So whenever you have difference in keratometry, use other machines. Do it on different days. Optimize the ocular surface. That's very important. So you'll have to use, obviously I'm presuming that your machine is calibrated. Is well calibrated and well standardized. But if in case you're getting a difference, then it is always better to do multiple readings on different days and then take an average of that.
Good morning, everyone. Thank you, Dr. Vinita, for having me here in this course on biometry. So I will be talking about biometry in special situation. I don't have any financial interest. The slides are not moving. The slides are not moving. Yeah, thank you. So I would be primarily talking about longer axial length of and shorter axial length, sulcus placement of IOL, silicone filled eyes, and post VR surgery eyes. So why are we considering this long and short eyes? Because the effective lens position, which is the most very important component of IOL power calculation, it is assumed to be similar for all the types of eye. Suppose we have a longer eye, that doesn't mean that there would be effective lens position which will be always the similar. Because in longer eyes, anterior chamber depth might be great, might be deeper, but this won't be always there. So accurate measurement of effective lens position is very, very important. And then of course we need to be sure about the IOL availabilities. So effective lens position predictability can be calculated by various parameters like axial length, keratometry, horizontal wide to wide, refraction postoperative, anterior chamber depth, length, thickness, and of course the age. So what is the predictive IOL position? So it is the posterior part of the cornea and then anterior surface of the IOL. So it might vary in different subset of patients and also in patients in which the IOL is not implanted inside the bag. So we need to have personalized A constant, as Dr. Vinita has just now emphasized. We need to have 4th generation formula which are more accurate because there are 7 input variables involved in these formulas. So for extremely long eyes, whenever we are doing optical biometry, it is important to visualize the fovea. So swept source biometers, they can help to locate fovea in a better way and therefore are better for IOL power calculation. If we are unable to do on optical biometer due to some of the other reason like mature cataracts or dense PSCs, then immersion is way to go. Now, because in myopic eyes or the longer axial length, we have low scleral rigidity, therefore contact biometry should not be done in these patients. We also need to aim for a slight amount of myopia of -0.5 or -0.75 in these eyes. And if we have an axial length of more than 27 millimeter, then contact biometry can produce all big amount of errors. So we should be careful about these. So whenever we are talking about myopic eyes, now this was a very good study in which they found that high myopia is associated with variable biometric measurements, and that can be due to variety of problems. Now, we don't have isolated myopia only, we have myopia in other ocular disorders like retinopathy of prematurity, exudative vitreoretinopathies, Marfan's, Stickler's. Now, the thing is that in ROP group, they show significantly shorter axial length despite being myopic. Similarly, in Marfan's group, there is significantly flatter corneas despite being myopics. And same as with the Stickler syndromes group, they have longer axial length compared with inherited myopias. So we need to keep these points in mind while we are calculating the IOL power. So this was another study, and they found that Haggis and Barrett Universal 2 formula have a better success rate in predicting IOL powers in high myopic eyes with longer axial length. So Barrett Universal 2 or Haggis with optimized A constant is way to go. In these myopic eyes, we need to adjust the optical biometry axial length, which is suggested as a Van and Cox modification in JCRS. But I think Barrett Universal 2 is the formula which is quite commonly used these days and gives a very good results to all of us. And because it is also available free online, therefore we can all use this particular formula. drhill.com or ascrs.com is the website where you can go and check with these formulas. Now coming to extremely short eyes, because these eyes are extremely unforgiving, therefore IOL prediction should be very particular in these eyes. So small errors in axial length measurement, they have disproportionately larger effect. So change of axial length, say from 20 to 19, will change the IOL power by 5 diopters. So small shift in effective lens position also causes big refractive surprise because the lens is thicker and it is closer to fovea. Hofer Q is supposed to be more accurate if we are using ultrasonic biometry, but fourth generation formulas, they are always preferred in such eyes. Now coming to sulcus placement of IOL, here we need to follow the formula of 9S. So suppose we have axial length between 17 to 28 diopters, we need to decrease by 1 whenever we are planning to place the IOL in sulcus. Suppose you have a posterior capsular rent and now you are placing the IOL in sulcus, you need to reduce by 1. But if the patient is having IOL power of less than 18 diopters, then you decrease the IOL power by 0.5 if you are planning a sulcus placement of IOL. But if you have the power is more than 28 diopters, you need to decrease the power by 1.5. So if optical biometers are not available like in hard cataract or mature cataracts and dense PSC, you can do immersion A scan, even if you can also increase the gain to get those readings. Now coming to post-vitrectomized eyes or silicone-filled eyes. Now because speed of sound is slower in oil than in vitreous, and therefore usage of standard sound velocity can give error up to an extent of 8 mm in these eyes, especially if it is silicone-filled. Therefore, ultrasonic axial length that overestimates the IOL power in silicone-filled eyes, and moreover, there are problems of multiple interfaces, there is sound attenuation, and there is low scleral rigidity also. So, optical biometry should be done in these eyes, and it has been found to be 10 times more accurate than any other conventional method. So these silicone oil filled eyes or silicone oil dependent eyes, the problem arises when optical biometry is not available, and sometimes dense media due to advanced amount of cataract leads to fixation problem, and immersion with increased gain is the answer. Another important point is you should make the patient sit, because once the patient lies down, the silicone oil interface that changes, and that can cause variable readings of axial length. Now here, because the velocity inside the silicone oil is different, therefore we need to apply this factor if you are not doing it on some advanced 4th generation formula. So normally the sound velocity which we use in all the biometers is around 1550. But here, if the silicone oil of 5000 centipoise has been used, the velocity you need to feed in is 1133 or 1140. So what we do, we take a factor, like we use 1133 divided by what is the velocity which has been fed in the machine. So we get the A constant of 0.72, and that should be multiplied in the measured axial length to get the correct total axial length. Similarly, if silicone oil used has a 1000 centipoise of gravity, then you need to take the sound velocity of 980. So you will be dividing 980 oblique 1550, and that would be multiplied in the measured axial length to get the correct axial length. You need to aim for higher power of 2 to 3 diopters in these eyes which are silicone filled. So to summarize, I would say that optical biometer with swept source is the answer for best of your readings. But if it is not available or you are unable to perform, go for emulsion biometer, and then Barrett's formula online, Barrett's 2 is the good formula to use in all such eyes. Thank you so much for your kind attention.
So I'll be taking the next talk, that's on the science of pediatric biometry, which is Ayani. Yeah, so I'll be talking about how to do and what all challenges we faced while doing pediatric biometries. So obviously, although we are dealing with child, but it's not as simple as playing with a child. So despite the dramatic differences and revolution which has taken place in the field of adult cataract surgery, the field of pediatric cataract surgery is still lagging behind in terms of especially the IOL power calculations. So why is it different from that of an adult? because we are choosing an optimal IOL power for a child eye which is still growing. So we are implanting a fixed power into a growing eye. That's the biggest problem, biggest challenge which we have. Younger the child, more difficult is a problem. And we are remember, we are using formulas which have all been designed based on calculations being done for the adult eyes, not for the pediatric eyes. Besides this, the formula issues which I have talked about is one important issue, the choice of the IOLs, the measurement issues, which is very, very difficult. In younger the child, more is a problem. The formula issues I've already talked about, and the third major issue which is there is the growth of the eye, which is taking place with time, or the myopic shift, along with the visual axis opacification, which is another thing. So what is the target refraction which we are supposed to target is again very, very difficult to decide. So now, if you look at this chart, we know that there's a normal curve of how the eye grows. At birth, your axial length is around 16 to 17 millimeters, and there is a rapid growth occurring during the first three months, and thereafter it gradually grows till about the age of almost 18 months to 2 years, and then the growth is very, very slow. For the keratometry, there is a marked variation which is occurring from 51 to 43, flattening occurring during the first 18 months. For the lens power, marked decrease occurring in the first year of the life of almost 10 diopters, a change in the lens power because of the change in the curvature of the lens. So all these changes, as I said, are markedly occurring usually during the first 2 years of life, 1.5 to 2 years of life. So the maximum amount of myopic shift, as seen in various studies, is again in the same duration, same time duration. So as I've already listed, let's look at the factors which affect this myopic shift. The normal eye growth pattern for everybody, the age at what time we have operated the child for his cataract, whether we have placed the IOL or not, whether it was a unilateral or bilateral cataract, the genetic influence which comes from the parents, and the visual input, whether for how much time period that eye was deprived of not seeing clearly. Besides this, the other issues are, as I said, they have a different anatomy. They are not the same as adult eye. They have a shorter axial length generally, a steeper cornea with a higher keratometry readings, and a deeper and a smaller AC. So the standard IOL power formula which we are using for the adult's eye are inadequate. This is because obviously in these cases we are doing ultrasonic measurements, and the ultrasound velocity from different components is different. We all know that. Second issue is the growing eye, which I've already talked about. So the parameters are changing as the growth is occurring. Then the third issue is the measurements in the office settings. Obviously, for most of the children, we are not able to do in office settings. And we are usually using our manual instruments, manual refractometers or handheld autorefractometers. Otherwise, we'll have to take them under anesthesia because of the measurement issues in the OPDs. So in the anesthesia, obviously your orientation is not straight. Your eye may not be looking exactly straight. So you'll have errors in measurement arising because of that. Then you're using again ultrasonic measurements. Best would be to use immersion, but still with that also there are chances. If you're not able to use immersion for some reasons, then obviously you will have more chances of compression. And remember, these children have a lower ocular rigidity, so the effect of compression is much more impact of compression as compared to an adult eye, which will be around 2.5. Here the compression is 3.75 diopters per millimeter. Look, go back to your formula which I talked about, 2.5 millimeter into keratometry, into axial length. Here it is 3.7 diopter per millimeter of axial length difference. This I've already talked about. So lack of fixation within when you're doing measurements in anesthesias, and also the accuracy of the handheld keratometers for the cylindrical measurements. It's not very accurate. Then the problem of non-availability of all these handheld instruments with every surgeon. Also, infants have a different steeper keratometry. As they grow older, their keratometry lessens down, the steepness reduces. Girls have steeper keratometry. And also it has been seen by studies that bilateral cataracts tend to have more steeper keratometry readings as compared to unilateral cataracts in children. So the errors of axial length measurement I've already talked about. Applanation obviously will cause more errors as compared to immersion. Immersion scan would be recommended if you're using ultrasonic. But the best, as I said, because the velocity of ultrasound is going to vary, so the best is to use the scarf method, measure in the aphakic mode, where you're using the velocity of sound as aphakic mode of 1532 millimeters per second, and then add 0.32 millimeter to the axial length to get the actual axial length, or the corrected axial length factor as we call it. Optical biometry, wherever you can do that. Obviously, this is more accurate. And the effect of cyclopegia also has to be considered. Don't dilate before doing your optical biometry, which again, Justine would cover up. So I'm not going into details of this because it causes changes in the things. IOL power calculation issues also I've talked about. So obviously, these are derived from adult data. And remember, obviously, these are smaller eyes, so the actual IOL power which will be calculating will be higher. It requires more actual exact axial positioning or more exact ELP determination in these cases, which we are not able to determine. So as a result, we have less predictable IOL positioning in these cases, leading to, because of the various factors which I've already listed earlier, as greater vitreous pressure, steeper corneas, capsular contraction, which is again very commonly happening post-operative in these cases, and the unpredictability of all the formulas, all the various formulas, and more the variability, younger the child. As an pediatric cataract surgeon, I would always still prefer to hit the target. So the desired goal to hit the target would be according to the age of the child is to undercorrect. Higher the IOL power, more will be the undercorrection. Bilateral cataracts, more than target for more undercorrection. Unilateral cataracts, you need to create a balance between the two eyes. You want to minimize the anisometropia. If the normal eye again has a significant refractive error, then probably again balance for the refractive error of the other eye. If the amblyopia is dense, then again aim for a lesser hypermetropia, because the compliance with the amblyopia therapy will be poor with the high refractive error left as a residual refractive error. If poor compliance, again leave with a lesser refractive error, try to emmetropize the child in these cases. So what I do in my practice is for unilateral cataracts between 2 to 4 years, normally I take a calculation of spherical equivalent of the fellow eye, minus 1.25. More than 4 years, I usually make it as equivalent to the fellow eye. For infants with bilateral cataracts, less than 6 months, now I started implanting IOLs even at 4 months. Earlier I was doing it after 6 months, but now at 4 months I've seen it's better to implant the IOL. So I'm aiming for a moderate hyperopia depending upon the other eye factors of 3 to 7 diopters. Infant aphakia treatment study also recommended the same. For 6 to 12 months, I am aiming for a milder hyperopia of roughly around less than 3 diopters. We have pediatric IOL calculators which are available, Windows-based programs which are available online. And these are general undercorrection guidelines which can be followed of percentages. It is usually lesser than 2 years, which is more controversial. For above 2 years, it's very straightforward of 10% undercorrection or even lesser as we move with age, reduce 1% per year of age. And best choice would be in the back placement of IOLs and doing an optic capture of that. Piggybacks is a choice in some cases, especially as primary piggybacking, where you're placing one IOL in the capsular bag and one in the sulcus. And the one in the capsular bag is the actual IOL power, which will be calculating for the emmetropic without the undercorrection. And the one in the sulcus is the difference between the two, which you can remove at the appropriate age. And the type of IOLs, I'm not touching on this. This is not the part of the talk, so I'm just skipping this part. For the secondary IOL calculations, because there may be a lot of children who have been left aphakic at the time of primary surgeries, it will again totally depend upon whether you're able to place the IOL in the bag, in the sulcus, or in the anterior chamber. Remember, any power which is placed more anterior in the eye will have a greater refractive error than it will place more posterior. So your position, IOL power calculation will have to be done accordingly. Especially in these cases, if the child has been on soft contact lenses for hard contact lenses for a long time because of his aphakia, then it is important to remove the contact lenses for a longer duration, at least 2 weeks before you take the keratometry readings. And you can use these axial and the K values just by using the aphakic refraction also. So there are formulas for that. So I'm just skipping this also. The secondary IOL for piggyback IOLs, which is done as for refractive surprises arising in children, we can have these secondary piggyback IOL calculations. So in the end, I would just say, try to customize for each case, depending on the age, the laterality of the cataract, the visual acuity of the child, and the amblyopia status, the likely compliance of the child and the family, obviously the caretakers of the child, as regards to glasses, contact lenses, and the amblyopia therapies, family history, the genetics have to be taken into consideration, and also whether you are placing the IOL in the bag, in the sulcus, or in the antechamber. Remember, diligence is very, very important in these eyes, because these are not just miniature adult eyes, but they are growing eyes, and careful consideration to every changing parameter in these eyes will make a big difference to your outcomes. Thank you. So I now invite upon Dr. Jasleen. She'll be talking about some of the queries which the audience had about the biometric fundamentals. What things should be taken into care while you're doing your basic measurements?
Thank you, Vinita. It's showing here. Should I escape it over here?
Mukesh will be talking about post keratometry IOL power calculations. Post keratoplasty, sorry. Yeah, sorry. Post keratoplasty. Sorry. तुम्हारा भी सेट ही हो रहा? हो गया? तेरे में क्या प्रॉब्लम हो रही है?
He said he was showing, but now it's not.
तू दोबारा पेन ड्राइव में ले ले. पेन ड्राइव में ले ले.
डुप्लीकेट पे नहीं गया, वो एक्सटेंड पे गया, इसलिए नहीं दिख रहा है.
क्या हो गया?
Thank you, Dr. Vinita, for giving me this opportunity. So I shall be talking about the IOL calculation and the penetrating keratoplasty scenario or the corneal transplant scenario. So this is a 63-year-old gentleman who came to us for the visual rehabilitation. He had keratouveitis earlier in the eye, which has led to scarring as well as endothelial decompensation. So we had to basically do a corneal transplant, plus there was a cataract, so we decided that we will do a triple procedure. So conventionally we generally take 44 as the standard K, or we take the keratometry of the other eye. In this particular case we took a standard K of 44 for this patient. Axial length was 23.65 in optical biometry, and then we implanted a IOL of 21.5. So it was a uneventful surgery, did well after the surgery. Immediately post-op, 20/125 was the vision. However, after 6 months, the vision dropped to 20/320. So what happened? So now the spherical, his refractive error was -10 spherical and -12 cylinder. So why this happened? You can take a look at the topography. So the K reading, which we assumed would be 44 after the surgery, had become about 48 K1 and 55 K2, and the average was 51.8 K, and the maximum K was 59. So this was much beyond what we had taken a conventional standard K of 44. So that led us to think that maybe this is a time to change the conventional way of doing a corneal transplant, and a triple procedure is not giving us a optimal refractive outcome. So now that the cataract surgery has become more of a refractive surgery, these kind of outcomes will not be acceptable to the patients and will not give a very good vision to the patient. So now that we have a very good safe technology of phacoemulsification, we have viscoelastics which are very good, which can protect the endothelium. Probably we have to look beyond the triple procedure. So triple procedure was started way back in 1976 by Taylor, and this is about 50 years ago, and this was the time when aphakia was the norm. Okay, the patients would use very thick glasses after surgery and they were fine with it. But the times have changed, and also there is a risk in the triple procedure. Those of us here who do corneal transplant would know that triple procedure, doing it in a cataract surgery in an open sky, is not a very easy surgery. There are risks involved, and if there is a upthrust, there is a problem in doing the ECC and putting a IOL. So, and as I said, there is variable refractive outcomes in triple procedure. So, in this particular study, they saw that the refractive outcome could be as varied as minus 14.7 D spherical to plus 8 spherical. Okay, so there is a difficulty in calculating IOL power in triple procedure. And what K value should you use in triple procedure? That's also a challenge. Conventionally, as I said, we use 44K, but some people also use the K of the fellow eye when it is available. And there is one study by Salahuddin, he has used a donor K of the the keratometry value of the donor eyes. So while the eyes were being enucleated from a disease, they took a keratometry on the donor eye, and that is the standard K which they use for their IOL power calculation. But that's not the norm that we generally do. But I believe that now the time has come to shift to sequential procedure, which would give us a much better refractive outcome. So this particular study, they studied 22 patients where they had keratoplasty done, PK done, and along with that the ECC was also done, but patient was left aphakic and IOL was implanted later on once the K reading had stabilized. It takes about 6 months and beyond for the keratometry to stabilize in patients of keratoplasty. So you should, if the time permits, you should do a keratometry after 6 months, and based on that you should do the the biometric calculations and put the IOL, which gives you a much better. So in this study they got 95% of the patients were within plus minus 2 diopters when they did a sequential surgery. And also in this particular study they did keratoplasty followed later by cataract surgery, so that also gives you a very good IOL power calculations because you have a stable keratometry in these particular cases. So when should you consider triple procedure? I would consider triple procedure only when the cataract is very advanced and if I do a PK now and a cataract surgery later on in a very hard, let's say grade 4, grade 5 nuclear cataract, then it will lead to a significant corneal damage, endothelial damage. So that is when I would probably do a triple procedure. And there too, now I have started doing a PK and a cataract extraction and leaving the patient aphakic and putting in a IOL later on. Okay, so I would do a PK first and then later on do the cataract surgery if the cataract is soft. If the cataract very hard, then I will leave the patient aphakic and implant the IOL later on. That's what I have started doing now. So in this particular patient, he had a adherent glaucoma and a PK ECC plus IOL was done, triple procedure was done, and as you can see the refractive outcome was -3 sphere and -6 cylinder. Compare this scenario to this particular patient where I did a PK first because it was a soft cataract. Later on, about 6 to 7 months later, when the keratometry readings had stabilized, then I did the cataract surgery based on the stabilized K, and here you can see the refractive outcome is plus 1.25 sphere and minus 0.75 cylinder, approximately plus 0.5 is the spherical equivalent. So much better outcome, refractive outcome as compared to a triple procedure. If you are doing DSEC, then the situation is actually a little reverse, because in this situation either you will do a combined surgery, or in my scenario I would prefer to do a cataract surgery first and then do a DSEC. Here the calculation is very simple. You do the cataract surgery, you aim for a minus 1.5 refractive error, and because your DSEC will cause about hyperopia of about plus 1.5. So you keep that into account. So your target is about minus 1.5 when you're doing the cataract surgery in a patient who has Fuchs, where you would do either a combined surgery or you will do a cataract surgery later followed by DSEC. So this is the simple calculation for DSEC. In DMAC again the calculation is a little similar, but here the hyperopic shift is just about 0.5 plus 0.5, so you take a target of about minus 0.5. So DSEC and DMAC is lot more simpler than a PK. Thank you for your patient listening.
So now I'm right upon Jasleen. Jasleen will have to cut down the shots, so make it at least shorter, crisp and shorter in 6 to 7 minutes. Yeah. Mic.
Yeah. So just covering the basics of biometry, particularly the tips and the traps that we can get, take advantage of. So in this era where cataract surgery means a refractive outcome for the patient, it is very important for a cataract surgeon to be well versed with the nuances of biometry and to use that data to determine the ideal intraocular lens power. So first and foremost, we need to identify what is the goal. Is it emetropia? Because sometimes we may not actually be choosing emetropia based on the patient's requirement and the other eye status. So it's very important to take accurate measurements, collect that data, use the appropriate IOL formula, particularly the newer generation formula, and as Vinita has covered, optimize for the best result. It's important that when we are considering intraocular power calculation, we should not, be handling the cornea. So we should, for instance, not do an applanation or a gonioscopy that day. You're going to change the readings. Always have a trained optometrist or do it yourself and be well versed with the technique, with the machine, with the data entry. Be very careful that you are entering all the data appropriately, and your optometrist should be able to pick out anything which is a red flag, and always take multiple readings, always measure both the eyes, make sure that your instruments are calibrated regularly, and look out for the unexpected. So for instance, if you have an asymmetry in the two eyes or you have extreme values, you must repeat and double check these readings. So if you have an axial length of less than 22 or greater than 25 millimeters, a keratometry which is too flat, less than 40, or too steep, more than 47, a difference in the two eyes of axial length more than 0.3 millimeter, or a keratometry of greater than 1 diopter, an astigmatism which is over 1.5 diopters, a difference in the IOL power calculation of more than 1 in the two eyes, then always repeat and confirm your readings. So what are the basic components? By and large, we used to consider the keratometry and the axial length in the two variable formulas. But now there are multiple measurements that are there: the white to white, AC depth, lens thickness, refraction, and the age. Why so? Because like Dr. Shalini had covered, we have to calculate the predictive or the effective lens position, and that does not always follow a rule that shorter eyes would have a shallow AC depth or a longer eye would have a deeper AC depth. And therefore, multiple variables addition is making the IOL power calculation more fine-tuned. So keratometry is mainly measuring the corneal power, and we measure the anterior corneal curvature here. We are assuming the corneal refractive index to be 1.3375. And this keratometry is, it's not causing a lot of error when we are talking about the IOL power calculation in eyes that are going for a monofocal IOL. But in case there is a toric power, then the keratometry becomes very, very important, because then the inaccuracy can lead to an error of in as many as 27% of patients. So in case, see, when you are doing keratometry, it's very important that the eye should be well lubricated. The cornea, the positioning should be central. And the person should be off contact lenses if they are usually using contact lenses. Make sure there is no scarring, and calibrate your instrument very, very well. Approximately an error of 1 diopter in keratometry leads to a 0.8 to 1 diopter error in the IOL power calculation. So both the manual K and the optical K do well, particularly if it's done by someone who's trained and the instrument is well calibrated. But the optical K is now integrated with the IOL master and all these machines, so it is fast, reliable, and quick. So oftentimes we are going for the optical K now. The axial length is the most important parameter for an accurate IOL power calculation, and it is also the most common source of errors. And a small error can lead to a much larger effect in the refractive outcome. So it's very important to focus on the axial length measurement and to make sure that you are taking the optical and not the anatomical axial length. So this is the reason that nowadays we are going more for the optical equipment like the IOL Master, because it's going to measure the true optical axis. So the true optical axis would be to the macula and not the actual anatomical axis. In case we are using the ultrasound, then we prefer to use the immersion, because the chances of compression of the cornea and falsely having a lower axial length become lesser. And make sure again that the instruments are well calibrated, and in case you are doing the immersion, then you make sure that you get good spikes, you adjust the gain. And if you do it along with the B scan, you are able to make sure that you are taking it in the optical axis. Preferably, we take the biometry measurements before we dilate the pupil. Yes, so this is the accuracy that we see. Of course, when we are doing the optical biometers, the accuracy is much more as compared to the contact or the immersion A scan. Choose the appropriate IOL formula. By and large, in the normal range of axial length, most of the formula work well. Nowadays, the Barrett Universal 2 is being commonly used, as it covers a lot of eyes, even hyperopic, myopic, post-refractive. So, like ma'am has already covered, for the extraordinary situations, which powers to be used. Yeah, so I hope that it's clear and your patients are able to, be very happy with the refractive outcomes. Thank you so much.
So I'm a little short on time. I'll try and see how I can finish. So the first topic is post-cataract surgery refractive surprise. It's better to be safe and rather than sorry later. So these are the eyes where you can have refractive surprises. So please be extra careful when you're dealing with these kind of eyes, and do all the necessary steps which have been elaborated by my previous speakers. If it does happen, then you need to figure out why it happened, and then you need to look at everything. Could it be because of a scar, or is it because of irregular cornea? Is there possibility of a capsular distension, IOL malposition? Was it a biometry error? So you need to go back and look at everything. If necessary, repeat the biometry and see where things went wrong. And then you have to think about how you want to deal with it, whether you want to change the lens or do a piggyback lens or do some sort of a cornea-based procedure like an ablative refractive surgery. And if there is some other cause like a capsular distension or the lens being malpositioned, then you have to address that surgically. So in the immediate postoperative period, it's important to recheck everything, including IOL calculation in pseudophakic mode, check the preoperative data, IOL power calculations, make sure that the right patient has the right lens. Sometimes you've done everything but you put the wrong lens in. And rule out a capsular block syndrome, which can cause a myopic surprise. So if it's a multifocal lens and patient comes, say, 2 to 4 weeks after surgery, it's a good idea to just change the lens. But if you're not keen to do that, you could put a piggyback as well. But if the patient is coming several months after surgery, then it's likely that the IOL would be adherent to the capsule to some extent. And in such cases, better not to damage the capsule and just go ahead and put a piggyback lens if that is feasible. Otherwise, you can do a corneal ablative refractive surgery like a LASIK or a surface ablation. If it is a monofocal lens, up to 4 weeks, IOL exchange, piggyback, and surface ablation or LASIK, all are good options. And more than 4 weeks later, then again piggyback or a surface ablation or LASIK. But if you're doing a femtop flap, make sure that the hinge is at the wound site. Toric IOLs, if the IOL gets rotated, then one could rotate it back to the original axis. If you do not have the original calculation, then you could use these websites like astigmatismfix.com, or if you have a ray tracing aberrometer like the iTrace, that will help you to identify which is the correct axis in which the lens should be played. Excimer, either wavefront guided ablation, not a topography guided ablation, IOL exchange or a piggyback IOL could be used in extreme cases. So this is just the website of astigmatismfix.com. You just need to put in your data and it will then give you a calculation of what should be the new axis of your lens and how much you need to rotate. IOL exchange, this is a video I borrowed from my friend Harshul. So basically what you could do is you could put in the bring the first lens out of the bag, put in the second lens in the bag before you explant the second the original lens, which is like it acts like a scaffold, and then you can go ahead and cut and remove the lens so that you don't accidentally damage the capsule and there is some protection of the other lens. So this is just one case I'll share with you. This was a patient that had an uneventful cataract surgery, and you can see lens is looking well in place and eyes quiet, but we had a refractive surprise of 2 diopters. And as you can see on the slit, there is a gap between the PC and the posterior surface of the IOL. So this is basically a capsular distension syndrome. The viscoelastic was not adequately removed, and same thing is confirmed on the OCT. You can see the gap there. So one can try to do a yak to the peripheral anterior capsule, or you could yak the posterior capsule, or you can go in and do a visco wash. So in this particular case, we did a yak to the peripheral anterior capsule. You can see that star shaped mark over there. Same thing is visible on retroillumination. And postoperatively, immediately the patient's refractive surprise resolved. Of course, the prevention of this is to do a good OVD wash. So go behind the lens also and wash it out. This is another patient, 61-year-old female, underwent a multifocal IOL 6 months prior, and then after 6 months when she came, this was the kind of refraction I was dealing with. So very, very unhappy patient. Obviously, she wanted unaided near vision and distance 6 and 6, and this is what we are giving her. So what happened in this case is there was a phimosis which has displaced the lens anteriorly, and there was a change in the effective lens position as well. Plus, I think there was some calculation error as well. So what we did in this case was we planned for a piggyback Sulcoflex toric because there was also a cylinder. So this is made from Care Group. We also have from Reina similar lenses, and we just excised the entire phimosed anterior capsule and opened up the anterior capsule, we subsequently then put the secondary piggyback lens in the sulcus, as you will just see. So you have to inflate the sulcus and then basically take this lens and inject it anterior to the anterior capsule. It's pretty good option which is now available to us because Care Group makes it, and you just need to tuck it in like any plate haptic lens. And this patient, you can see the 2 lenses on the slit, did very well and was unaided 6/6 and 6 subsequently. So ideal candidate for a piggyback lens is primary IOL should be intact and the capsular bag should be intact, pupil, iris, everything should be healthy, and of course endothelium, there should be no glaucoma, etc. So this is the way to calculate for piggyback lenses. If it is a hyperopic error, spherical equivalent to 1.5, myopic error spherical equivalent to 1.2. And Sulcoflex is the other one from Reina. So to conclude, refractive surprises are best prevented by good biometric practices and surgical safety practices, and can easily be treated by cornea and lens based approaches with good outcomes. Do we have time, or should I skip the last talk? Is there another session after this? Okay. Ajay. So I'll quickly finish it. I'll run through it quickly. Next. Okay, so this was originally not my talk, so anyway, I'll present it and hopefully I'll do some justice. So we'll talk about post-refractive eyes. So corneal refractive surgery alters the basic assumption on which the biometry for IOL calculation is based, which is a perfectly symmetrical nature of the cornea. With the rise in popularity of refractive surgery, which we've been doing for a few decades now, there is an increasing number of patients with a history of laser vision correction or incisional refractive surgery which need cataract surgery. So many of those patients are now coming with cataracts, and as we know, myopes do develop cataract earlier. So they would even come in their late 30s or 40s with cataracts. And there are two complicating factors here. One is that these patients have an extreme of axial length, either high myopia or hyperopia, for which a refractive surgery has been done. And then the corneal shape has been altered, so your keratometric calculation and effective lens position goes out the window because of the alteration that you've done with the refractive surgery. So you have difficulties in IOL power calculation, you have difficulties in selecting the type of IOL. We recently heard about the case of Shah Rukh Khan, who had a major problem after his cataract surgery, and that was essentially because he had a hyperopic LASIK and the surgeon had put in a negative aspheric IOL. In such a case, actually you would want to go for either a zero aspheric or maybe a positive aspheric lens, which probably was overlooked. So it's important to choose the lens according to the refractive surgery. Post-operative visual acuity is again a very important thing in these cases because they are post-refractive. They are used to unaided good vision and they expect the same thing after the cataract surgery, and if you give them anything lesser, they'll feel that you didn't do as good a job as the first LASIK surgeon, and they will always be unhappy, how much ever you may tell them. And of course, these eyes are always prone to surface problems and dry eyes, and you have to deal with that as well. So what are the sources of error? One is the formula error. Virgin's formulas use K to estimate the effective lens position. Flatter Ks lead to underestimation of the ELP and vice versa. Keratometrics index error. Standard keratometrics index of 1.3375 is based on the constant anterior posterior ratio of the cornea, which is obviously altered, especially in ablative refractive surgeries. In incisional refractive surgeries, that ratio is still preserved, and this tends to overestimate the corneal power by 1 diopter for every 7 diopters of correction of refractive error. And instrument error, most of these take keratometry from a 3.2 millimeter zone, missing the central effective zone. Flatter the cornea, greater is the measurement zone, hence greater the error. So this is just a diagrammatic representation of ablative versus post-incisional refractive surgery. So as you can see in the incisional refractive surgery, there's an alteration of both anterior and posterior curvatures of the cornea. Whereas in an ablative, the posterior remains the same and you're only altering the anterior. So the ratio between the anterior and posterior is significantly altered in them. So if you had a hyperopic ablation, then you cause a central flattening and a positive spherical aberration with a smaller angle kappa. And if it's a myopic, I mean, and if it's hyperopic, it's a central steepening, negative spherical aberration, and a larger angle kappa. So all of these result in either underestimation of the IOL power in a previously myopic correction or overestimation of IOL power in a previously hyperopic correction. And this is essentially what we are trying to avoid. And there have been loads of formulas, as you can see. There are almost 25-30 formulas which have been described for correcting, for getting accurate IOL calculation in post-refractive eyes, which are based on several things like history, changes in manifest refraction without prior data, and other formulas. So I will just run through some of the important ones. Rather than understanding how each formula works, I think for us, a lot has been made easier by all these online tools that are available, and we are clinicians, we don't have to waste time as long as we know what to take from that and how to apply it appropriately. I think that is more important. So how can we obtain the true so problem is in the correct corneal power, which is being altered because of all these reasons which I just mentioned. So earlier we were using the clinical history method, in which we use this formula Ka is equal to Kp plus Rp minus Ra, where K is the estimate of the corneal power after surgery, which we want to calculate. Kp is the actual measured reading before surgery. RP is the spherical equivalent before keratorefractive surgery, and RA is a stable spherical equivalent which should have been hopefully documented after surgery. In this, sometimes you may have questionable accuracy, you may not have documents, you can't really go on what the patient says, you know. They will say 3 diopters, but it may have been 3 diopters with 2 cylinder, and that totally changes the spherical equivalent, you know. And not suitable for RK because of the unstable corneal power, as we know. It keeps changing in RK patients. Contact lens over refraction method is a very useful method described by Ridley, in which you use this formula, which is K is equal to BCL plus PCL plus RCL minus RNOCL. So BCL is contact lens base curve, PCL is contact lens power, RCL is contact lens over refraction, and RNOCL is the spherical equivalent of the manifest refraction without a contact lens. Now, you have to, of course, go put a rigid lens over the patient's eye to be able to do this, and which is a bit of a cumbersome thing. Disadvantage is the accuracy worsens when the vision is less. So if you have a dense cataract, you can't really get much reliable readings with this. Topographic based post LASIK adjustment. So you can use the central topographic readings from the topography and use Koch and Wang formula. You can use TMS system or some other systems which are available. The newer tomographers, OpScan, Pentacam, etc. will give you information of both the anterior and posterior corneas. So these are especially useful when refractive data is not available, because they can measure both anterior and posterior curvatures. So OpScan is a little less reliable. Pentacam and the IOL Master 700 are definitely better tools if you have them. And a double K correction method using the Koch and Wang nomogram adjustment significantly improves, and it is useful for SRKT, Hoffa-Q and Holiday, not suitable for post-RK. Haig's L formula is a built-in software in the IOL Master, which uses the regression approach based on statistics, based on LASIK data, and only suitable for post-laser vision correction cases, not for RK. And basically it applies a correction curve to the existing measurements to derive the effective corneal power, which you can then input into your which is then inputted into the Haig's formula and the IOL powers calculation. Similarly, recently they have also developed a hyperopic version which also works reasonably well, and it's a useful tool, because in these cases we always used to struggle earlier. Now ray tracing machines are now available which actually avoid the formula errors, and basically they calculate the refracted ray at both the anterior and posterior surface, and are supposed to be very, very accurate. I don't have much experience with these, but some of the machines like Sirius, Galilei and Oculix and iTrace barometers, you can use these. So Pentacam uses this EKR power map. You can see these two graphs. This is the ideal EKR, which has a narrow base and a single peak, whereas if you have a very wide base, then it means that the keratometry is irregularly distributed, and you may not get a very reliable value in this. And basically this is a map which gives you an equivalent K reading, which you can then input into your IOL formula. For both myopic and hyperopic LASIK, a 4.5 millimeter optic zone, the zone calculation for the EKR is quite useful for the calculation. So we have this ASCR's online calculator, iolcalc.org, and that really makes our job easier. It uses various formulas, as has been mentioned here. And if you go to the website, you have 3 tabs: prior myopic LASIK or PRK, prior hyperopic LASIK or PRK, and post RK. So depending on your case, you select the tab, you input the data from all your different machines that you may have, Pentacam, optical biometry, manual case, etc., etc. And whatever input and clinical history if you have, and whatever inputs you have given, based on that, whichever formulas are applicable in this website, it will give you the output. And from those you can choose. So I think it makes our job easier. We are clinicians, we are not physicists, and you have to fill in this thing, and it will give you an output. In general, I always, in myopic errors, I try to go with the highest corneal the IOL power that is available, unless it's a very big outlier. So always err on the side of more myopia, and it's okay to end up with myopia than hyperopia in these post myopic refractive surgery eyes. Post RK is a totally different ball game. Do I have time? So here the ratio between the anterior posterior is greater in the central zone and smaller in the paracentral zone when compared to normal eyes. And there's a lot of element of irregularity also, because these are manually made cuts, so the cornea is not very uniform. And third problem is there are diurnal fluctuations. The K values change from morning to evening and over a period of time. So that gives us a lot of problems. Second problem is with the optic zone. It is often less than 3 millimeters, and we usually calculate our Ks from around that optic zone. So if it will actually come at the junction between the flat and the steep cornea, the so-called shoulder, and this results in an overestimation of the corneal power, and you can end up with significant hyperopic surprises in these cases. So we always target myopic in post RK. If it's a 8 cut, go for a -1, 12 cut -1.5, and 16 cut, aim for -2. How to measure the K values basically that's what you are trying to do in both post LASIK and post RK. You can take central measurements, you can actually put your cursor in the center of the cornea and take multiple readings, and this can be used, but it's a little cumbersome and not very accurate. Post RK IOL formulae are available, which basically again are double K formulae. Use various formulae like SRKT, Holiday, and Hoffer-Q based on the K value and axial length to determine the effective lens position. So pre-RK Ks are used for the ELP correction, and post-RK Ks are used for the corneal power correction, and you can use the true K RK algorithm, DK Holiday IOL master algorithm, and Potwin Hill. In the ASCRS calculator, it uses the effective refractive power, which is basically taking all points from the central 3 millimeters, and these are applied for the IOL power calculation. If you have an Atlas topographer, it takes the average powers from the 1, 2, 3, and 4 millimeter rings, and basically it's again using central corneal power. And if you have a IOL master lens star, it uses the double K modified Holiday 1 formula using a pre-op K of 43.86 and post-op mean K from the IOL master or the lens star. So the true K formula is probably very useful especially if you have history, clinical history. So either complete history or partial history formula is preferable if you have historical data. If you don't have refractive history, then you can use the true K no history or the Haigis formula, where the ELP is calculated using axial length and anterior chamber depth. OCT is another tool, especially if you have the OptoView OCT. It can give you the net corneal power calculation using the OCT readings as well, and I use this routinely in my clinic, and I found it to be quite accurate. So and then once it calculates the net corneal power, you can input it into whichever formula you want to use, and there's also an Excel sheet in which you can just input your data and it will calculate the K value to use. Finally, as Dr. Vinita had mentioned earlier, you can do, whenever in doubt, do an aphakic refraction, and then you have various formulae which are available for aphakic IOL calculation, and you can use that data to kind of calculate the lens power in very cases where you're suppose you're getting a lot of disparity, or your cornea is very irregular, you're not sure what kind of result you're going to get. You can do that. You can do intraoperative refraction, or you can do with a gap of 1 or 2 days and put the lens in. Thank you.
Rishi, would you use a multifocal IOL in post LASIK ever?
I have used, yeah.
And what are the results?
So I think you have to look at the topography. If it's like a very uniform topography and there's no decentration, I think you can go ahead and use, because these patients basically desire spectacle
these are
independence.
patients
Yeah.
who
So and I
never
have
get to
used
wear
I have used
spectacles.
trifocals and bifocals also, but you have to use it selectively and you have to tell them about possible problems
So
that they might
what
face.
has been your experience in terms of the target, and were you able to achieve?
So I've used it in limited cases, but in all the cases that I used, I got a good result. I didn't really have to do any other intervention. So I think you have to selectively choose. Now that we have EDOFs, I think they are more forgiving. I would now err towards pushing them. This was when I didn't have the option of EDOFs. So I would probably now suggest those. Again, you have to keep in mind whether it's a myopic or a hyperopic LASIK and select your lens accordingly. So if it's a post hyperopic, you should go for the Rayner lens rather than which has a zero Q value. Yeah.
Thank you.